All right, good afternoon, everybody. Thanks for being here with us. We appreciate your time today. I got just a few slides put together here to run through, and then hopefully should have a relatively quick meeting for you guys, which pretty much guarantees I'm going to take it right up to 30 minutes, but we'll see where we get to. Did have just a couple kudos to throw out there. I saw Miss Laureen's on here, so kudos to St. Francis County Ambulance District for hosting an event and seeing some of their kiddos. So I appreciate you guys meeting your families and having them come up to the station. Also, have been giving some shout outs to especially some of our further outlying agencies that are still managing to implement the full stack of stars from dispatch to transport, including sometimes flight back to St. Louis for some pretty sick kiddos. So I've been shouting out Stoddard County Ambulance District for that one as well. And then also just thank you to everybody around here who's making this program work. It is a community effort to help protect these kiddos. So did have just a couple or two call reviews to run through. That's what a couple is. And first one, I think I'm able to chuckle about because it has a good outcome. So I think we can all laugh a little bit about when Stars Life intersects with Midwest Life, and your Stars patient is involved in an ATV rollover. Kudos to him for living his best life. Fortunately, it was a very low speed event that just got kind of hung up, but did flip and roll the UTV over and did eject the patient. It was unfortunately did land on a pretty good oak branch and managed to get a puncture wound from that. Just a few other things of note that especially my EMSers in here can appreciate. There was off-duty sheriff's personnel on scene who tried to cancel the ambulance on the way and say they would take themselves, but kudos to the ambulance for continuing the run in and did meet the family with the patient in the back seat of a car. The family and bystanders had attempted to tourniquet the leg themselves around the puncture wounds, and it was not a very well placed half bandage slash half tourniquet. So EMS did end up removing it and fixing the situation and controlling the bleeding. Did some good wound care. And then what I think, as always, we kind of step into that pretty phenomenal next level stuff. So they did look at this kid's history, and he has a history of congenital adrenal hyperplasia. He's at increased risk of adrenal crisis whenever he gets injured. This was clearly an appropriate use of it. And so they went in and gave him a emergency dose of dexamethasone for the ride in, and then just always, good comfort care. They did also give him a stuffed animal, which I joke, we want our patients to have good outcomes and feel good in the back of our rigs. But also, these are still traumatic events for a patient who's probably undergone a lot of medical trauma himself already. And anything we can do to diminish that, there's lots of people in the world who are starting to acknowledge that and address that. So just kudos on, I'll go and give them their name and shout out. So this was Big River Ambulance, and they did a really phenomenal job by their stars patient. So. And then I was going to address another one real quick from last month. So this is a syncable episode for a 17-year-old. And so that 17-year-old is of note because he recently did get an LVAD placed. This was his first day at home from hospital discharge. And your first day at home, why not go enjoy a little bit of time at Swing Around Funtown there in Fenton? But unfortunately, did have a sinkable. Very fortunately, his family did catch him as he went to fall, and were able to keep him from being injured from that event. They did end up running him back to us. Just a few takeaways from this one. First of all, kudos to Melanie, who worked very hard to get this plan done quickly. He kind of had a precipitous discharge that almost caught us off guard, but did have the plan in place from the day he did go to get discharged home. And kudos to Finn, who was ready to deal or ready to help him. So just, kind of if I could speak to that takeaway from this, that first 24 to 48 hours at home for our high-risk medical patients, you guys know as well as I do, if if you've been running 911 calls for a while, but so frequently that is where we see an emergency almost pop right back up again. I think that's probably a lot of factors that go into that, but the family really is, kind of leaving this full support all your food's provided, your meds are provided on a regimen, like everything's there. And then just we kind of start to really introduce that chaos of returning to home life, and then also just not having, the support personnel to ask questions to, like, is this normal? Is something going wrong here? What should we be doing here? And so, if I could speak slightly to this patient's case, and I think he'd be okay with it because he caught his fair share of lectures after he was back. He just wasn't drinking nearly enough fluids. It had gotten volume down a little bit within that first day at home. Um, and then just kind of fascinatingly, especially for those of you who like to nerd out with me on advanced EMS stuff. So whenever they do cardiac caths at our hospital, they do put the diagram in with the pressures. I had never seen one with the LVAD in place before, so just for your enjoyment, that is what it looks like in the diagram whenever they're doing the cardiac caths and documenting the pressures with the LVAD. So nothing that impacts your field care, but just a little bit of fascinating for us. And then I did want to just highlight one other case. I'm going to cheat a little bit because this one's actually from early April, but I thought there were a decent number of talking points, especially for some of my more distant agencies and hospital staff. So this is a well-known STARS patient who attended her local community hospital. And so just some things I want to call attention to. So she had come in some respiratory distress. They were trying high flow, but they were really kind of concerned with her. She was struggling to maintain SATs even on high flow. And just to point out that even this is actually a transport team's trip sheet. But what you see here in these first notes is like they're using the form, just the most basic form, STARS form, to start the conversation with the doctor. Obviously, that needs to go to higher levels above and beyond even what we write in STARS. But just, yeah, I think your crews, especially if they've got time or they're trying to figure out things from further away from Glennon, use that to talk to the attending at the hospital. Same thing at Children's. You can use that over there. But use it to kind of inform your discussion of like, hey, just so we're clear, we're talking about this patient. It's just not a little normie running out here. We know some more history about them. Some other things that are kind of come down through here. So they were really pretty certain that, concerned about airway here if they can't maintain SATs on high flow, and they decided that they were going to need to intubate. So they kind of use that to continue to drive the conversation. I will say that anesthesiology at the outside facility was able to make an appearance and show up and assist with the actual establishment for the transport. So just kind of using the STARS form to help facilitate those conversations whenever you're trying to decide, next clinical decision-making steps can be beneficial. And they acknowledged, both in our form and in the Epic chart, this kid is a known difficult airway, and they had that discussion of, weighing out the risks versus the rewards of whether to go for that procedure. It is, of course, always nice to have an anesthesiologist walk through the door whenever you're having that conversation as well. So they got the benefit of that. I will say the other thing about this call is just kind of acknowledging challenges of vascular access, which we talked about some last month, but just to reiterate again, they could not get a line started on this kid. She'd been sick for a couple days, probably was a little bit volume down. And they did have to IO, but we also unfortunately lost that first IO after the RSI process as well in this kiddo. So I just really wanted to emphasize this is an ongoing problem. I don't think any one thing's going to solve it. I think we kind of heard Doc Laffey talk about it last month. Obviously, we need to come out with more training about it. I hope EZIO comes out with some more training about it so that we can maybe revisit the skill in pediatrics. I feel like in some ways, we as providers, we were a little bit better at IOs and peds before, but I feel like something about adding easy IO availability for adults, we're now very proficient with it in the adults, but we are seeing a lot of struggles and misses in the kiddos. I did just in case you didn't know, if for any of my training officers on here, Teleflex actually has a ton of resources for this as well. In fact, I was going to pull up their website here for you. I promise I am not getting reimbursed or paid by Teleflex. But just to emphasize, they have a lot of training and education resources for you to share with your staff with your fellow providers, all kinds of videos, paper documentation. They have some on-demand education as well, to kind of review your landmarks, review the process, review how to do it all. And certainly something that I think is worth adding to, your pediatric month education, or any other venue. We're going to be talking about the kids a lot. So just seeing if we can't, maybe revisit this, get, know our tools, and kind of get these skills back under control. Um, and there is also an app that has the additional training resources as well. So I certainly will not tell any of you what to do at your agencies, but just know that it's kind of an ongoing problem. It's not always caught well in QI feedback, right? I mean, a kind of a classic story, even from when I was on the street, is, oh, we put the drill in, and then later on the ED figured out it wasn't good, or it had gotten dislodged, or whatever the story is. But that means it's not always documented in a way that we catch it in our QI process. And so just to know kind of from hospital side that it is happening, and we'd kind of like to, let's see if we can do something about it, right? Because it is a valuable tool and a valuable skill to resuscitate kids. And let's just, make sure we're doing it the best way possible. So. All right, so Calvin Day. For those of you who remember from last year, this is certainly not a mandatory day, but we hope you'll have some fun with it. So as you guys all know, our sample plan, Mr. Calvin Hobbs, is star 417. So for those who want to participate, we'd kind of like to establish a little bit of a tradition on April 17th, to practice dispatch, or practice logging into our accounts. We kind of discover as we go through the year, sometimes cell phone numbers have changed, or services have changed out other things. So, I'm not saying you have to necessarily, I'm sorry, I'm just looking at Nicole, like, you don't necessarily need to send this to all 500 of your providers at MedStar, but like, especially from agencies where it's going to individual trucks, a few of those phones haven't been registered, they haven't been authenticated, or the phone numbers have changed. So just, have some fun with it if your dispatch is playing along, or if your crews are up for going to their truck phones and logging in, just to see if they can locate star 417. And we'll just kind of use it as a day to make sure everybody knows how to access and use the system. So, and feel free to tag our social, or our Facebook site if you want, to make a deal out of it, and we'll see if we can all generate just a little bit of buzz about doing the right thing. So for the numbers, we actually, since our last meeting, have added 38 new stars. So the plan writers have definitely been busy. Year-to-date logins, we currently have Central County's got a slight lead out there. So, but kudos to all my dispatch agencies. You guys are doing awesome at this. I don't even show up on there anymore. You guys are trouncing me. So dispatch is looked at just about dead even for March. So 51 for this year versus 52 for last year. So still seeing good use out of that. For known calls, we had 24 known 911 transport calls for March. Kind of not seeing much change in the documentation. I obviously would like to see that, but maybe we'll work on an initiative a little bit more in the future. Just, it does help us, at least know that the crew saw it, acknowledged it, acted on it, didn't act on it. But just kind of gives us some help when we're doing all of our chart UI. So it's always appreciated. And then looking at reasons for calls. So we're just documenting the top 3 for each month there. But you can see respiratory and seizures are still kind of dominating. Airway management still pretty strong for the year. Just one for March there though. And then you can just kind of see some of the other medications and routes. I'm not going to dwell on any of that too much. I am going to spend just a moment talking about this. So real strong direct to tertiary for the month of March. So you can see 95% of the kids just came directly to. As far as stopping out the outside facilities, I know anybody who's heard me give the Balancing Act lecture, we're really kind of looking at this a lot these days of, okay, if you had to stop an outside facility, what actually happened, and how long were you there? And so you can see our outside hospital times there. So I guess I won't count Switch or hold that against them. That's just an interfacility transport at that time. But for the others, you kind of get a sense of sometimes it can be real fast, but even between the same facility, like there really is a lot of variability depending on how quickly transfers are available. And sometimes the kids can sit out there a pretty long access reasons. Even more this year, we're continuing to see education and training climb. So kudos to you guys. I can't wait till education and training is half of it. Like, right, like let's just prepare for the kids and look at their plans in order to get ready for the emergency versus just responding to an emergency. Just a reminder, I know you guys have heard me say this a few times, but we continue to update the flyers and kind of refine the list as we head towards it. So we are going to host that inaugural STARS conference on Thursday, June 11th. The doors open at noon. It'll be from 12:30 to 5. So we're going to have some good topics, good speakers. I see I got Mr. White on here, who's going to speak about Cox Health's community paramedic initiatives. Danny Lee will be talking about how this fits into some of the EMS readiness. Dr. Finney's going to talk about ketamine use for seizures. Glaffey's going to talk about adrenal crisis and use of steroids. And then we're going to try to talk about some, current updates and trends on some of our other, say kiddos that we write plans for, and just want to kind of provide that. Hey, here's the newest, latest, greatest information that we know. And so hopefully you guys will be able to attend. Like I said, it's a $25 standalone, or if you're already coming to the Glennon Trauma Conference, it's free to attend the STARS conference. So hope you guys will be able to come join us for that. We do continue to have some swag if you guys want to support the STARS stuff. I do not make any kind of commission yet. I guess I should talk to Bubbles about that, but feel free. That will be in the slide deck whenever we send it out from this meeting. The one other thing, I don't have a slide in here for, but I can send it with the meeting notes afterwards. We're going to do our Train the Trainer course coming up May 1st, where we're really hoping to kind of get some of the training officers, the educators, any of our Star Super champions and who are interested, but starting to look at what does it look like to have you guys teach the things that we come out and teach, right? So that whenever we send you a new STARS plan and you get that email and it says, hey, you've got STAR 3000, they have pulmonary hypertension or they have a cuffed trach with a vent. Okay, and you have crew members asking you, and I don't expect you to be experts in it. I don't consider myself an expert in any of it yet, but at least, okay, well, I understand the basics of this. This is how I navigate the emergency. So we're hoping to give you some resources for slides, potential training ideas, psychomotor drills, just different thoughts for how we can start to really ensconce this within our agencies, right? Like I want us to continue to raise the tide here in this area. I am of the belief that in this area, in the St. Louis region, we should have the best pediatric care available in the country in EMS. Like, you guys can do it. You're all pretty advanced. We're cutting edge protocols, and we're willing to do the education and all the training resources to try and keep that stuff up. So certainly where my head is at, and that doesn't need to come entirely from people working at children's hospitals. I think that can come from the EMS agencies themselves. So that's the goal of Train the Trainer. This is going to be kind of a beta course to test it out and see how it goes and get some feedback. So if any of you are interested in that, it's free. We'll give out some CEs on May 1st. And feel free to drop your name in the chat if you just want me to go ahead and include you, or I'll send out the invite for that with this meeting list. So now that I've covered an entire slide that isn't present, are there any comments, questions, concerns that anybody had or needed me to address today?
Nick, I have a question. It's Natrice from Warren County Ambulance District.
Hey, Natrice.
We have never participated in Calvin Day, and
Okay.
I was just looking, does STARS 417 turn up on that day, or how does that
So
work?
yeah, so it'll still be hidden from you at baseline, but if you click that all stars and type in 417, you'll be able to see it. And we kind of intentionally leave it that way because it's a way to practice like finding kids who aren't associated with your agency. Please let me know if it doesn't work, but it should work.
Thank you.
Yeah, no problem. Any other questions or concerns from the crowd? All right. Well, thank you all very much. I hope nobody will be too upset with me if we ended a little bit early. But I'll hang on if anybody wants to address me in a smaller group. So.